Hello and welcome to the first in a three-part series aspiring to excellence, focusing on systems and system failures, including the Francis Report as an example, as well as quality in healthcare. I am Adam Dolby, Chair of the Queen's Healthcare Leadership Forum, and I'll be presenting the next three podcasts in this series. If you would like to leave feedback on this series, please do email us at healthcareleaders@qub.ac.uk. Okay, so here's just an overview of the Excellence series, as we'll refer to this series of three podcasts from now on. Part 1, which you're watching now, is on systems and system failures, where we'll focus on what a system is and what system failures are, including examples of system failures. In Part 2, we'll have a look at the Francis Report as an example of a system's failure and what such failures mean for patients and what they mean for the National Health Service as a whole. And in Part 3, we will look at the concept of quality in healthcare and the different aspects of quality that there are in healthcare, and perhaps how they can be measured and how students even can help improve those areas of quality. In the first part of this series, we're going to look at why all of this is important. Then we're going to look at systems and what systems are, what a system is, and define it. And then we're going to have a look at systems failures and some models for analysing systems failures. So, what is this all about? Well, we're looking at quality, systems and system failures, the patient journey, the patient experience, and learning from the past with our Francis example. So overall, it's all about management and leadership, terms which are defined at other places on the QHLF website. It's about creating a culture in the National Health Service that's open, transparent, and is always focused on quality and the patient experience. It's about resource allocation and how resource allocation can be aligned with quality. It's about the ethical implications of a service which is free at the point of use and the rationing that's required in order to make that service sustainable in the long term. It's about improving outcomes for patients. It's about the politics of healthcare. In a nationalised healthcare system, there will always be tensions between the professionals and the politicians and the members of the public, all of whom have different expectations and different knowledge, and all have different priorities. It's about dealing with demographic change. As you may hear in the media from time to time, or pretty much every week, there is an increasing in the age of the population, and this is having consequences for the healthcare system in that it's increasing demand, and this increased demand has to be paid for at some point. But above all, it's about making sure that the NHS is sustainable in the long term. As we will see in the part of this series on the Francis Report, if there are many more repeats of things like Francis, the National Health Service may become a national laughingstock and may not be in existence for very long. The medical profession, including every single healthcare professional from all professions involved in delivering healthcare, must learn the lessons of Francis and Mid Staffordshire in order to ensure that there is continued support in the public domain for the National Health Service. So, systems and system failures, Francis and quality in healthcare. I'm going to start off by taking a look at why all of this matters to you as healthcare students or as healthcare professionals, in whichever profession you may be from. So it matters from a financial perspective. Here are just a selection of newspaper articles that have a financial focus that have been in the press in the past couple of years. So in the top left, there's an example of a lady who had breast augmentation on the National Health Service, and another girl who received a broken nose as a victim of domestic abuse. And that article shows that the girl who received the breast augmentation received it on the National Health Service, but the girl with the broken nose was unable to receive plastic surgery to fix her nose on the National Health Service. So was that right? Is it right that somebody who just wanted their breasts to be bigger should be allowed treatment on the National Health Service at everybody else's expense, whilst somebody else, who had her nose broken through no fault of her own, was unable to get that fixed. There's also an article written by doctors about charging an entry fee to some National Health Services, so removing the concept of free at the point of use in the National Health Service. Examples where this has been suggested include charging a fee to see a general practitioner, or charging a fee to present to A&E. Would that be right? Would you approve of that? Would you feel comfortable with that? Would that improve the quality of the services that have been delivered? And there's another example that you can see of some parents who had to raise £1 million to pay for the drug treatment for their child who had cancer. Again, is that right that parents should have to raise money to fund the cancer treatment when there's a National Health Service in existence? But obviously funding is limited in the National Health Service and you have to find a way of limiting it. So these leadership and management issues affect everybody, and they affect the care that you can deliver personally in the future. And they also affect members of the public, in that they may or may not be able to gain access to certain services based on decisions that have been taken in order to best manage the funding that's available to the National Health Service. And on this slide are some other news stories that have been in the press recently, just based around general quality and other political issues concerned with the National Health Service. So there's the story about the increased rate of deaths at weekends in the National Health Service. There's a story of patients who have had mistakes in surgery, such as instrumentation being left inside them. There's a local story about the so-called A&E crisis that's been happening in Northern Ireland. There's a lady who had to pay for 2 funerals for her baby, as organs were removed without consent following the death of her child. And there's the story more recently that's happened on gagging clauses within the National Health Service to prevent whistleblowers from speaking out, and the amount of money that has been spent on that over the past few years. Hopefully this has now stopped, and people will be free to speak out about failures in the National Health Service from now on. This will hopefully improve quality and patient experience within the National Health Service. So what we're now going to look at is systems and system failures within healthcare. So what is a system? In my view, it can be defined on a few different levels, 3 specifically. So there's the healthcare system, so you can view the National Health Service as a system, or the American private healthcare model as a system. This can be changed on a political level. It's not really something which can be decided by individual doctors or individual leaders. It requires political consensus within a democracy. The other level of systems of delivery, so how a specific service is delivered within that healthcare system. So the example that I've put down here is about a one-stop shop for breast cancer clinics, for example, and about GPs as the gatekeepers. So in the United States, under their system, you can present to, say, a gastroenterologist consultant in the hospital. In the National Health Service, you always have to go through your general practitioner to be able to access secondary care services. And these are decided as a kind of consensus level amongst consultants, so there's not really a political drive for them as there is at the other level, but it's more of a level by professional consensus of a best way to deliver a certain service. And in the case of general practitioners being the gatekeepers, that's kind of another level that's decided at a political level, but there is a little bit of room for manoeuvre from a professional point of view. And the final level that I think systems can be defined as, systems as processes within an organisation which produce outcomes. So, for example, a system whereby you reduce negative outcomes in surgery, such as the World Health Organization surgical checklist that's used throughout the world and has been shown to reduce morbidity by 1/3 whenever it is used. Another example may even be as mundane as the process for discharging patients and the communication that results from that between primary and secondary care. And even more mundane, perhaps, is the process that people go to when they get blood taken, and the steps that the healthcare practitioner follows when they take blood. So do they ensure safety by providing gloves, using safety cannulas, by ensuring that they've checked the right patient that they've got in front of them with the wristband, or by asking the patient their name and date of birth, which is obviously particularly important when it comes to group and cross-match with blood transfusions. So that's the general definition of a system, as defined on 3 levels. The healthcare system, through which healthcare is delivered on a grand scale. The systems of service delivery, which are how services are delivered within that system. And also systems as processes, which occur every day and are undertaken by individuals. As this talk is aimed at healthcare students, our main focus will be on systems as processes, as these are likely things that students would have influence over or would be able to do some small research or audit projects into, rather than a system as per the bigger scale definitions, which are unlikely to lend themselves to research and audit projects by students of healthcare. So now I'm going to talk about systems failures from the point of view of a system as a process within a healthcare service. So systems on this level are processes intended to ensure patient safety, service quality, and a good patient experience. But they're not foolproof. All systems can fail, and failures result in harm. So a system failure is therefore when the use of that system results in a negative outcome or results in harm. So there are 2 example models that I've provided that you can use to look at systems failures. So wherever an adverse outcome occurs, you can look at the system to try and analyse how to stop that failure happening again once you've identified the source of the failure. So the first model is the Swiss cheese model. So if you imagine each stage in the process is represented by a piece of Swiss cheese, as shown in the diagram. Each stage in the process has holes in it like a piece of Swiss cheese, and these holes are where the system can fail or where the process can go wrong. As there are lots of pieces of cheese, these all line up so that you try and get through the system without allowing the holes to line up. So if 1 or 2 holes line up in a 4-stage process, it doesn't matter. Where all of the holes line up, it does matter, and that results in a failure and in harm, and that is thus defined as the system failure. So you need to uncover how all of those holes manage to line up and produce the adverse outcome in order to prevent it from happening again. So for example, say you were working on a surgical ward, and there were 2 patients coming in to have a leg amputated. One was having the left leg amputated, and one was having the right leg amputated. Obviously, you'd want to chop off the right leg on each patient. So your pieces of Swiss cheese would be basically methods of checking the identification of your patient. So the nurse would check the identification on clerking them in and give them a wristband. The doctor would check the identification on clerking them in. The nurse taking them down to theatre would check the identification and would also mark the leg. And there would be a double check on the identity in the operation site before the operation began. If all of these stages were missed out and the wrong patient was identified, then there's a risk that the wrong leg could be chopped off. So in the model, those different pieces of cheese, i.e. the checks on identity, are used to try and prevent harm happening to the patient. Where all of those are missed out or go wrong somewhere and the holes line up, then there is a failure of the system and harm results. The other model that can be used for analysing system failures is the bucket model, where you look at the problem by splitting it up into different elements, so the self, the context, and the task. And on the next couple of slides, I'll go over an example using Ranson's bucket model to try and analyse a system failure. So sticking with our theme of amputating the wrong leg, I'm going to use that as an example of a systems failure and use the bucket model to try and analyse the problem. So, thinking about the self. So what self-issues have caused the system failure? Well, there could be inadequate sleep of the surgeon or the team. There could be poor training. There could be issues at home with regards to the surgeon, so he's distracted. They could be unaware of the World Health Organization protocol and so not use it, or not want to use it. The members of the team may be unwilling to challenge the surgeon who is carrying out the procedure. Maybe that surgeon has created a culture of fear, and that anyone who confronts him will live to regret it, so no one dare suggest that he may be chopping off the wrong leg. Perhaps the surgeon is overconfident and so doesn't think that he needs to bother checking the identity or checking which leg he needs to be chopping off. Or maybe the surgeon or other members of the team are stressed or under the influence of alcohol or drugs. So thinking about the context, what contextual elements could have led to the system's failure? So the staff may have been worried about their jobs due to recent cuts, and they may have been distracted as a result of that. The operating theatre may have been noisy due to building work outside. There may be political issues between different members of the team. There may be poor lighting in the theatre so that the mark couldn't be seen clearly. There may be an inadequate handover of the patient from the nursing team on the ward to the nursing team in theatre. There may be unfamiliarity with members of the team. Or maybe the doctor's bleep keeps going off so that he gets distracted or forgets to hand over certain details that may be important. And finally, from the point of view of the task, there may be a lack of cues to guide the surgeon. So for example, the leg may not have been marked by the nursing staff on the ward or the medical staff on the ward. There may be what we call a fixation error, where the surgeon is so over-familiar with the procedure that he's carrying out that he can't notice that it's going wrong, or that he's stuck in a certain mindset where he doesn't think about important details like, is it the right or the left leg I need to be chopping off? There may be a new way of working that's recently been introduced into operating theatres that creates an unfamiliarity with the task. Or maybe the surgeon or other doctors or nurses are distracted by other work that has to be done at the same time, and that the surgeon may be multitasking by also answering questions from the junior doctors. So, using Ranson's three-bucket model, I have just demonstrated how problems in healthcare, i.e. systems failures, can be analysed using a set model looking at the context, the task, and the self. Whilst on placement, you may wish to use this model in any system failures that you suspect that you may have seen in order to try and analyse the scenario to prevent such a mistake happening again by suggesting system improvements. So why are systems and system failures important, and why is it important to understand system failures? Well, systems result in what is provided to patients. And where something wrong, harm results. And where harm results, the newspaper reports it. And that may eventually lead to an undermining of the health service, either as a whole or as an individual institution, such as a specific hospital where things go wrong, such as in Mid Staffordshire. System failures are frequently referred to in the news, in public inquiries and government reports. And so an understanding of systems is vital to appreciate how the NHS has gone wrong in the past, and how it can be improved in future, and how we can learn from past mistakes. It's also an important skill to be able to analyse system failures, so that you yourself can think about how your own practice goes wrong, and try and prevent it from happening again, or from reviewing processes that you're seeing on the ward, and thinking about how they can be improved to reduce the potential of harm. So I'm now going to take a look at the patient journey. So a patient journey is what the patient experiences from presentation throughout the system, and a patient pathway is the route. So you can view the patient journey as the experience of actually driving on a journey, whereas the patient pathway is the roadmap. So here I've included an example of what happens when a patient presents at the start of their patient journey with chest pain. So I've mentioned that systems produce what patients experience. And so we're now going to move on to the patient journey and what the patient journey is. So I'll start off with an example of the patient journey. I'm going to use an example from England, just as a region that I'm familiar with. So we'll say it's 2 a.m. on a Sunday morning, and a gentleman calls 999, 69 years old, in Scarborough. He's a smoker, he has central crushing chest pain, which is 9 out of 10, and it radiates to his jaw and to his left arm. And so the ambulance crew arrive and take an ECG. But before you even get the ECG back, you consider that the top of your differential diagnosis in this case is a myocardial infarction, based on the history. So here's the ECG taken by the ambulance crew, which shows ST elevation, which I've circled in purple in leads 2, 3 and AVF. So these are the inferior leads and suggest an inferior myocardial infarction with ST elevation. So this patient is having an inferior STEMI. The policy in this local area, if an inferior STEMI, or indeed any STEMI, is suspected, is to call the local cath lab for that region and transfer the patient directly for primary percutaneous coronary intervention, the gold standard treatment. So here's a map of the area. The patient is shown as a purple dot, and the cath lab is shown as a red dot in Cottingham, just outside Hull. Distance Y is the distance between the patient and the hospital that does the primary coronary intervention. And the black dots represent hospitals which are nearer the patient than distance Y. Of course, these hospitals all offer services, but they don't offer this service because it's a highly specialised and very expensive to provide service, given that it's 24 hours a day, 7 days a week. Remember that it's 2 a.m. on a Sunday morning, and so the most efficient way of delivering this service is by having a single regional centre. And so this map very well demonstrates what happens when services can be centralised. So in this case, the patient arrives at 3:10 a.m., an hour and 10 minutes after the original call to the ambulance crew, and the patient is in the cath lab by 3:30 a.m., an hour and a half after the original event. An angiogram is performed in the cath lab and demonstrates, as we suspected based on the ECG, a blocked right coronary artery covering the inferior territory. A right coronary artery stent is put in place, and the patient is moved to the ward for the standard 3-day follow-up as an inpatient. The patient is then discharged on a statin, a beta blocker, an ACE inhibitor, and aspirin, as well as clopidogrel, because it's a drug-eluting stent that was used in this example. So overall, this demonstrates the journey that the patient has from the onset of symptoms, to what happens when the ambulance crew arrive, to when the patient is transferred to the tertiary centre, what happens in the cath lab, and the follow-up protocol, as well as the discharge medications, are all standardised so that the patient receives gold standard, consistent care. Remember, a point to raise here is that variation reduces quality, and so it is vital that variation is reduced in providing healthcare, but that's just a side point for today. So, this example has shown that cardiac services have been centralised in this region. Centralised services improve outcomes by reducing variability and increasing expertise by having people perform the same procedure over and over again at a specialised centre. They also reduce costs because you've got the equipment available in a centralised location that covers a large population. Its usage is 24/7, so the cost per unit time is reduced. Centralised services are evidence-based and improve outcomes overall. But is there a cost of access? If we didn't have a quality ambulance service, it wouldn't be a lot of use, because people wouldn't be able to access the service. So you need to consider these things as well. Patients also don't like local services closing, so if their local district general closes, there is uproar in the community, despite the fact that there'll be higher quality treatment at the specialised tertiary centres, because people are a little bit attached to their local hospital. People like keeping local services open, but it costs lives, arguably. It's politically difficult to manage quality, and so education of people must be the priority. As with everything concerned with human interaction, communication is the key. By politicians and healthcare workers communicating the benefit of these changes to the population at large, the more accepting the general public will be of the changes, and the more likely the changes will be to get through to result in an improved quality of healthcare provision. So overall, it's about the quality of the communication between the professionals and the members of the public to communicate them the benefits of the change that is happening, despite the fact that their local hospital is closing, for example. Remember that it's the members of the public who are paying for the service through their taxes, and so the system through which healthcare is delivered has to be acceptable to the population at large. So in summary then, a patient pathway is the best patient journey based on available evidence. They allow a reduction in the variation between care, which increases quality of care. Reduction in variation also improves efficiency, and the best pathway improves outcomes due to the fact that it's evidence-based. But there are, of course, political implications to these that we've discussed already, such as requiring the closure of local hospitals in order to centralise services. If you wanted some examples of patient pathways, simply Google Map of Medicine. So thank you for listening and watching this video podcast from the Queen's Healthcare Leadership Forum. You can join the mailing list by emailing healthcareleaders@qub.ac.uk. You can find us on Facebook, follow us on Twitter @QUBHealthLeader, or visit our website at www.qhlf.co.uk. We also have ongoing positions available for members of healthcare professions who wish to join the committee, particularly at the minute dentists and pharmacy students. So if you will be interested in becoming further involved with the Queen's Healthcare Leadership Forum, you can email healthcareleaders@qub.ac.uk to put your name forward to join the committee. Remember, we also have a local experience network that provides opportunities and experiences for healthcare students from all professions interested in looking at service delivery issues. If you would like, you can view our website for further details of available positions. Thank you for listening to this podcast, and I hope to see you at future events held by the Queen's Healthcare Leadership Forum. Part 2 and Part 3 of the Aspiring to Excellence series will be released throughout the current 2013-14 academic year on our website, so keep checking www.qhlf.co.uk.